Is the negative connotations of Medicaid deserved? That is a yes and no question. Medicaid in itself is trying to provide care for people who cannot pay for it, but it has many inefficiencies. Many people dislike it because of these efficiencies, because their tax paying money is being spent poorly. The government should provide private insurances with subsidies so that low income Americans can get properly cared for. When before going into the argument, there are some terms that need to be defined. First is Medicaid. Medicaid is health care for people who Medicaid is health care for people who come from low income backgrounds and some people with disabilities. The second term is Medicare. Medicare and Medicaid are different, but can coexist with each other. Someone can qualify for both Medicaid and Medicare, but the people who qualify for Medicare are people 65 and older. A private insurance can also cover healthcare needs. They they help they help people who can pay for their insurance, and they help deal with the money in the proper ways. Medicaid's history is complicated. Medicaid has grown significantly from the 1960s. It started with it started with Lyndon B. Johnson's presidency in in the Great Society. The Great Society was Lyndon B. Johnson's hope for America. He was hoping that America would become equal, that through these programs, the poor and the rich would come to equal playing field. It has grown. At first the first people who were enrolled were just under 1 million people, and it has grown since then. In the 1980s, it was just under. The budget has grown to $27 billion, and since then has grown from 19 from the 1980s has grown from $25 billion spent to $72 billion. The largest jump that we see, is from the the 2000s to our current today. It has grown from 64.5 million people enrolled in the program to 75 million people. The budget has also increased tremendously. The expenditures has increased tremendously. It has gone from $206 billion to $600 billion and counting. This rapid growth has caused many problems. It has caused a doctor shortage and more places for fraud and waste. This is where I will be focusing on my argument. Many politicians do not want to deal with this program because if they do, there's most likely going to be backlash, or they could lose their political status. The first problem with Medicaid is doctors' participation. Many doctors do not want to participate in Medicaid because of the underpayment. When a doctor is seeing a regular patient who's not in the Medicaid program, they see an opportunity for more money to be gained for their practice and for themselves. When a doctor is being paid less, they have less incentive. They have less incentive to be involved with the program. This makes sense for just about anything. When you work hard for something, you don't want to get underpaid for it because you put your time in and your hard work in. Doctors also do not want to participate in this program because it has shown it provides an overhead for doctors. The amount of paperwork and government involvement with them is very tricky and hard to deal with for a doctor. Another problem with this is doctors run a business. This business is supposed to see as many patients as they can while being as productive as they can. These doctors cannot be productive when patients either aren't showing up or the government has given the money to the wrong doctor. Patients sometimes do not show up, but that is not always their fault. This is because of public transport. Public transport has been a big problem, but the doctors can't do much to help it. So they're either forced to double book or they just miss a patient for the day. And that is very costly for doctors. The second problem is improper payments. An improper payment is when the government gives money to either the wrong person that doesn't qualify for Medicaid or the wrong doctor or an inadequate doctor. When there has been in 2018, there was over $63 billion in waste, and it has only grown since then. When some of these payments are going to unqualified doctors, when these doctors are unqualified, that means the patient might not be getting the best care, and this doctor is breaking the law by either not being well licensed, not having their license renewed, or seeing patients when they're not allowed to. When the money is getting given to the wrong person, this could either be the wrong Medicaid patient, or it could be someone who is involved with the with the government, but the money is being given to the wrong person. This obviously shows waste because if a person does not need that money, it's just going into someone's bank account to use it wherever they want. There are 3 ways that we can change Medicaid. The first is through a marketplace system. Like the Affordable Care Act, this system would be an outlet online for private insurances to put their insurance up on the website. The government would then let the Medicaid patients pick from which private insurance suits them best. This could be an insurance that just provides for the needs of the patient. The second reform would be from an HSA system. An HSA system would work like a debit card, but for medical expenses. This could work with the marketplace system because the private insurance would be getting vetted the money from the government, and the government would be giving the debit card to the person. This would help with the improper payments because instead of the government just dispersing money to a ton of doctors, it would then just be going to specific private insurances so that they can take care of the money without causing that waste. But with this HSA debit card, there is a possibility for fraud and waste. But there would have to be considerably more limitations on what that card can pay for. And this would be the limitations would be given from these private insurances. The third is block grants. A block grant is money that would be given either to the state or to the person. It is better when the money is given to the state then it would be given to the private insurance from the state. This would work well because it would go by state's needs of Medicaid patients. Every state has a different amount of Medicaid patients involved in the program. So not every state needs the same amount of money. This is where these block grants would be in place. These three systems would help Medicaid be more efficient and produce economic growth. It would produce economic growth because these private insurances would be in constant competition. This would help either lower rates for those private insurances, making that insurance look better to the government, making the government want to sponsor it more. Which if one was doing that, then others would change their rates, making it better for the patient and for the doctors now, because the playing field would be leveled, kind of like Lyndon B. Johnson said. Some people would argue that Medicaid should just be required for all doctors. One, this would probably cause more doctors it would probably cause an uproar in the medical community, because these doctors now would not be getting the same pay that they want, and it would be considerably more complicated to run a practice with this system in place. Others would argue that we should just have a universal health care coverage for all people. This would mean that Medicaid would cover every single person in the United States. While this might seem like a good idea and get rid of the private insurances, I think that it would most likely just grow the problems of improper payments, and it would also cause less doctors to want to be involved with the program. And it'd cause less doctors to come up and be doctors. There would be a shortage of doctors now because many doctors do not want to be involved with government industries. And because of that, practices would get overworked, and these doctors would probably quit after a few years of this. In conclusion, Medicaid has many problems, and with its goal being to provide the best care for these low-income Americans, that goal would be properly met with the three changes that I proposed, because doctors now would want to be involved with the program, and it would help with those improper payments. So now doctors will be getting paid to serve these patients, and the patients would be getting the medicines and care that they need. Thank you.
Great job, Holt. I'm going to let Mr. Bertram ask the first question.
All right, Holt. You mentioned some of the barriers that the Medicaid population faces. One of those was public transportation. I can imagine others such as language, childcare, lack of knowledge of their medical history, can't get off of work to come to. And you talk about moving this patient population over to private pay status. How does the change in wait times, the clinic no-show rates, those barriers change by going to private insurance for that population?
So this question kind of gets at a bigger issue with private transport, and it would just be challenge. That is a whole problem in itself that I'm not addressing in this paper, in this presentation or paper. But we would have to have doctors with the language barrier. We'd have to have more doctors be able to be prepared for that, and possibly have separate doctors for that occasion.
All right, Holt, kind of piggybacking off that a little bit. So government is providing, you talked about block grants or subsidies in your paper. Government is currently kind of funding, right, is funding Medicaid. Now that would shift over to private insurance companies. But what would stop those doctors who are currently denying Medicaid from denying these new subsidized insurance plans in the marketplace?
So, like I was saying, it would likely level out the playing field, and with those Medicaid patients and the people who are covered strictly by private insurances. And the doctors would most likely not even know that they're in the Medicaid system. The Medicaid system is just the people who are getting covered. It's not the private insurance. They would be covered by the private insurance, but the Medicaid program would be supplying the money for those private insurances. So you could have the same insurance cover a Medicaid patient and a non-Medicaid patient, and the doctors would most likely not deny service because of just that Medicaid title.
Hope the amount of waste that you cite per year, potentially as much as $75 billion a year, seems enormous. But when we compare it to the rest of government spending, it doesn't seem that significant. We recently passed a COVID relief bill that will cost us $2 trillion. We're likely going to pass an infrastructure bill worth another $2 trillion. We may end up racking up $6 trillion worth of additional debt in about 6 months' time. So 75 billion is less than 5% of any of those bills. Is 75 billion just not a significant amount of government spending anymore?
I would say when comparing to that, it's probably not seen that way, but waste is waste, and it's people's taxes that are paying for it still. So it would still help with reducing those improper payments to a minimum. And while that may seem like a small number, it's still a lot of money that is getting wasted.
Speaking of waste and inefficiencies, you talk a lot about how Medicaid makes improper payments, and this is leading to a ton of waste, not only in government spending, but also in these improper payments being improperly applied. And so, do private insurance companies also make these similar improper payments? And would that not increase then when we shift to those people that are currently on Medicaid over to private insurance?
So from my research, I've seen very few, if any, instances of improper payments. Now that could just be my scope being strictly focused to one area, but I've not seen those improper payments happen. And when adding those people, I think if the improper payments were to happen anywhere, it probably wouldn't be from the private insurance to the doctor. It'd probably still be possibly from the government to the private insurance.
Holt, in your paper, you mentioned several times how Medicaid doesn't provide the best care for patients. It's subpar care in some ways. Could you cite examples of some specific examples of what it looks like to see what private care looks like versus Medicaid care and how private care might be superior to that?
So like I was saying with the improper payments part, how those payments were being given to doctors who either weren't qualified enough. I think that's the biggest instance where you see it. Doctors are going to be prepared to give the best care they can by the time they get through medical school and schools like that. But when doctors get out of practice and out of license and they're still getting paid for work that is subpar, I think that's the biggest issue.
All right, Holt. In your paper and in your presentation, you talk about how Medicaid underpays, improperly pays physicians, these kinds of things. Is it that Medicaid is underpaying, or is it that private insurance companies are overpaying?
I'd say that it's very hard to tell because for me, it seems that Medicaid is underpaying because of private insurance's high rates, but there's not an initial cap that I've seen from those private insurances. So in each medical visit is probably going to have different rates just because of what it might be covering or what it's doing, but there's just no cap on it. So I don't honestly know what would happen there.
All right, Holt, I'm going to wrap up the panel with two questions back to back. First of all, does society, I wonder, have a responsibility to meet the healthcare needs of the underprivileged? Why don't we just totally do away with Medicaid and each person's healthcare is their own responsibility?
So as it stands right now, I find it, first of all, I feel it very unlikely that Medicaid would just get done away with. If anything, we're moving towards that universal healthcare I was talking about. But as Christians, as just being good people, and I think out of our hearts, we should provide for those people who can't afford for it. But I don't necessarily always think that's the government's job. But like I said, it's very unlikely that Medicaid will just get thrown away.
Let me ask a follow-up to that then. I mean, a long time ago, churches, denominations contributed a lot toward public health care for those who couldn't afford it or who couldn't afford as good a health care as they would like to have, which is why we have hospitals like Harris Methodist, right? Do you think that the church ought to return in some way to its former role of trying to provide more of these kinds of services for people who can't afford them?
I think that's what we're called to do as Christians. We're like in Sam's thesis, he said, when Jesus says we're supposed to take care of the least of these, I think they are considered the least of these when they cannot pay for that medical coverage. So I absolutely think that the church should provide for these people.
Okay. Last question. You note that doctors run their offices as businesses and make decisions about whether or not to accept Medicaid based in part on business considerations. Should doctors think in those terms, given that they're trained to help people's bodies heal, that they have kind of a humanitarian vocation? Shouldn't their primary concern be the humanitarian side of their practice?
I think that in itself should be, but we are all sinners. So people aren't gonna think of those other people all the time, but also you have to think of the equipment that they're having to pay for, the leases that they have to be on, and the nurses and people who help with those practices. There's a lot of money that is not all going to those doctors. It's going to everyone involved with it.
Now that's a good answer. My wife worked for a doctor once whose annual malpractice lawsuit insurance alone was $400,000 a year. $400,000 a year. That's staggering. Okay, we're done with the panel. On that happy note, let's move to the honest question. Hold, that was fantastic. Really was. All right, audience questions. Mrs. Baker.
Great job, Holt. I'm really proud of you. My question is this: I really don't know anything to speak of about Medicare. Now, I know that Texas has a program that's just for underprivileged children, CHIP. Would you advocate the same changes to the CHIP program as you would to Medicare?
So I haven't focused on that CHIP program, but I'd say if it is run like Medicaid, which I don't know if it has the same inefficiencies or anything, but if it is run like Medicaid, I don't know. It is a little bit harder since it is children that you're working with. That could help. That would be hard with participation rates as well, just getting a kid out of the house. But honestly, I did not focus my research there.
Additional questions? All right.
Oh, thank you for your presentation. Some more than 50 years have passed since Lyndon Johnson cast the Great Society upon the land. As you've had an opportunity to study the passage of that time, have you concluded that the benefit to the society is greater than the expense of expanded government dealing with the issue? Or do you believe that the expansion of the government has far outweighed the benefit that has come to the country through the Great Society Medicaid endeavor?
So I'd say with the inefficiencies, it's hard to see that it is a positive thing, because of doctors not participating. That's causing less care for those patients and inadequate. So I'd say it seems to be very negative, but people still are getting the medical help they need. And I think that is the thing that we should strive for. But with the government providing for it, it's very hard to see the positive with those people still getting care.
This is Barbara.
With the insurance companies, because you said the Medicaid, the government would pay the insurance companies, correct? Do you ever look at the willingness of insurance companies to work with the government on this?
I did not focus research there. I did not see that anywhere, but they are still paying taxes, so they are working with government a little bit. But I have not seen that very much.
All right, additional questions? I'm missing one apparently. There we go.
So would insurance companies be paid based on like how much the government likes that particular company? Or would it be based on like the number of people in Medicare who chose that insurance company?
So it would more be the people who are choosing that company would get more money filtered through them, just because that's where the money has to come from. But I could see that the government would like certain private insurances over others. So.
Are there any other junior questions while I'm here? You know, I'm getting old, all this walking back and forth. It's killing me. No? All right. You're just thinking about next year. You don't want any bad karma, right? All right, Mrs. Espinette.
Hey, great job, Holt. As we discussed when you were trying to narrow down your topic, my husband's in private practice, and his burden with Medicare is not just the reduced payments, but also the quality of life. They continually raise the bar as far as documentation goes and stuff that isn't relevant to the patient experience. And so I wonder in your research if the doctors are rejecting Medicare and Medicaid, not just on a quantitative basis based on how much money they're refunding, but also a qualitative basis based on their job satisfaction and their enjoyment of doing of meeting their patients' needs.
I have not looked entirely into that. But I mean, it kind of still comes down to the question of, are you serving people just to serve, or are you serving strictly for yourself to get the money that you want? So I think with motivation wise, that's where that decision is going to be made.
So Holt, this is close to home, right? Your mom's a doc, dad runs the office. The economics of it are real, and the economic impact on physician practices and hospitals is very real. You also highlight that the Medicaid program is predominantly funded by the federal government, even though the state has to contribute a significant amount. That those funds all come from tax dollars, which all comes from everybody's pocket. You alluded to the fact that you felt like society, particularly Christians, historically and should contribute to the care of those who are less fortunate. Therein lies the dilemma. Do we expect government through taxes to provide this care, or do we expect the church to provide this care? That being asked, I know this is a long question. Is it just, because this is very costly, is it just to institute a system that has multiple tiers of level of care, just so that those who are least fortunate can have some lower but significant level of care?
I'm sorry, I'm kind of confused on where you're at.
That's okay. That's okay. I'm confusing. My wife tells me that every day. What? Is it just to have a tiered system of care to where those who don't pay for it themselves can still receive care, but it's not whatever they want?
So, yes, there would be limitations, like I was talking about with the HSA and the debit cards. Those debit cards would only be paying for certain things that the private insurances would be allotting. So I think that might answer your question.
Where's Hsa? So bizarre. He's not here. Any other questions? Seniors? No? All right. Holt, you're done, man.